Welcome, curious minds, to another deep dive. Today, we're plunging into a world that's often overlooked, but has, well, profoundly shaped human history and continues to challenge us. The poxviruses.
Right.
Did you know that a single disease from this family, smallpox, killed an estimated 300 million people in the 20th century alone? Before its eradication, of course.
It's an absolutely staggering number. Really puts their power into perspective.
It really does. It forces you to consider just how much of our global story has been written, partly by these tiny invaders. Okay, let's unpack this. If you've ever heard of smallpox, or maybe monkeypox more recently, you've touched the very tip of this viral iceberg.
Just the tip, exactly.
But there's so much more to learn, and it's incredibly relevant to understanding our world right now, especially as we see shifts in global health patterns.
And what's truly fascinating here is how incredibly diverse this family is. Even beyond those well-known names that, tend to grab the headlines. Our deep dive today is built around an incredible resource, Chapter 196, from a leading medical text. It's really a goldmine of information.
Chapter 196. Okay.
Yeah, this chapter meticulously lays out everything, from the fundamental definition and the intricate epidemiology to the clinical aspects and even the nuanced approaches to treatment and prevention for a whole range of poxvirus infections. It's a masterclass.
Our mission today, then, is to help you dissect and really master this information, almost as if you were an elite professional in the field, preparing for, say, a critical challenge or a high-stakes exam.
That's the goal.
We're going to meticulously break down every key concept, every specific detail, to give you not just a comprehensive understanding, but a true command of the subject without feeling overwhelmed. We want you to walk away from this really appreciating their complexity and impact.
That's precisely our aim. In a world just saturated with information, a critical question comes up. How do we figure out what truly matters? How do we extract those impactful nuggets and then integrate them into a cohesive, actionable understanding?
Right, cutting through the noise.
Exactly. We'll guide you through these intricate details, connecting the dots so you can grasp not just what these viruses are, but why they behave the way they do, what makes them unique threats, and what that ultimately means for us, both as individuals and, on a global public health scale. Think of it as gaining X-ray vision into the viral world.
Okay, X-ray vision, I like that. So let's start at the very beginning, their fundamental identity. When we talk about poxviruses, what exactly are they? What sets them apart from other viruses you might know? Is there something in their fundamental nature that gives them a distinct advantage?
That's the perfect starting point. And if we connect this to the bigger picture, understanding their fundamental structure is absolutely key. It's the foundation for appreciating their unique characteristics and, frankly, the ingenious ways they interact with their hosts. Poxviruses, unlike many common viruses we hear about today, they belong to a family of double-stranded DNA viruses.
Double-stranded DNA. Okay, not RNA like some others.
Correct. And what's truly remarkable, really stands out in the viral world, is that their genomic structure is largely conserved across different subfamilies, genera, and species.
Conserved, meaning it's basically the same structure across the board.
Pretty much, yeah. The core setup is very similar. This conserved core is fundamental to their identity and, frankly, speaks volumes about their evolutionary success. It's a stable design.
That sounds like a remarkably stable foundation. But what does that conserved structure actually look like? Are there specific parts that do specific jobs, almost like different departments in a factory?
That's a great analogy. It's quite an elegant design, actually, and understanding it helps demystify how they operate. So the central portion of their genome is substantial. It can range up to 200 kilobases in size.
Wow, 200 kilobases. That's a lot of genetic information for a virus.
It is, and this core region is absolutely vital because it encodes all the open reading frames, or ORFs. Now think of ORFs as individual instruction manuals or recipes. These particular ORFs are essential for the virus to replicate itself, so making exact copies of its genetic material, and also for packaging new virions.
Virions being the complete infectious virus particles.
Exactly, the fully assembled viral packages that go on to infect new cells. So this central part is their master blueprint. It dictates their basic ability to exist and multiply. It's the engine room, like you said.
So the core is their engine room, allowing them to reproduce. Got it. But what about the other parts of the genome? Do those also play a role in how they cause disease or interact with us, their hosts? Because that's where it gets really interesting, isn't it?
Absolutely. And this is where the sophistication of poxviruses truly shines. It reveals a lot about their evolution and interaction with host organisms. The left and right ends of the poxvirus genome. They're distinct from that central core engine room. These terminal regions are fascinating because they encode genes specifically involved in immune evasion or host interaction.
Ah, so not just making copies, but actively messing with the host.
Precisely. Think of these as the viral stealth mode, or their highly specialized interaction kit. These genes allow the virus to either hide effectively from the host's immune system, making it harder for our defenses to spot and eliminate them.
Like camouflage?
Sort of, yes. Or they allow the virus to actively manipulate host cellular processes to their advantage, essentially turning our own cell machinery against us.
Wow.
Yeah, it highlights a critical evolutionary strategy for these viruses. They're not just passively reproducing, they're actively and strategically managing their environment within the host to ensure their survival and spread.
It's quite cunning. So if I'm following you, the core genome is like their engine, making copies, but those ends are their evolutionary secret weapon, a sophisticated stealth and interaction kit. That's a powerful insight. It's like a genetic blueprint that determines their personality in terms of disease.
That's a great way to put it, yeah.
Whether they're subtle or aggressive or with animals they prefer to infect. Given that, how many of these viral personalities do we as humans really need to worry about? How many actually make the jump?
Precisely. It's the viral equivalent of a special forces operative highly adapted to outmaneuver or manipulate our defenses. And to your question, that specific complement of ORFs found across different genera, the unique mix of all these genes, especially those immune evasion and host interaction ones, that's largely what dictates how diseases manifest and what hosts a particular virus can infect. This explains why some poxviruses cause, mild localized skin lesions, while others can cause severe widespread systemic illness.
Big difference in outcome.
Huge. And to answer your specific question, currently, 4 main genera of poxviruses includes species known to infect humans. But what's even more interesting, and this really underscores the ongoing nature of scientific discovery.
There's always more.
Always more. There's even an incompletely classified poxvirus that has been reported to cause human illness. It just reminds us that our understanding is always evolving, and there's always more to discover in this ever-shifting viral landscape.
Okay, so we have this fundamental understanding of their structure, their personality blueprints. Now let's turn our attention to how these viruses actually get around. How do most poxviruses spread? And are there exceptions that genuinely keep epidemiologists up at night? Because knowing how they move is critical for anyone aiming for that elite understanding.
That's the natural next step. And what's truly striking here, a key takeaway, is that the vast majority of poxviruses that infect humans are zoonotic.
Zoonotic meaning from animals.
Exactly. They primarily originate in animals and then occasionally spill over to humans. This animal origin also profoundly impacts their typical transmission routes. Most spread through direct contact.
Skin to skin, or touching contaminated things.
Both, yeah. Skin to skin or contact with infected animal materials. Crucially, they typically do not spread through the respiratory route, like, say, the flu or common cold viruses.
Ah, okay. That's a big difference.
It's a huge difference. This contact-based transmission makes them inherently less prone to causing widespread explosive epidemics, which is a critical public health point and often sets them apart from, say, influenza or coronaviruses. It limits their reach, generally speaking.
So contact is the usual culprit, which inherently limits their reach, but you hinted at exceptions. Which ones are the outliers that really worry public health officials because they can spread more broadly?
You've hit on it. The notable exceptions are certain species within the orthopoxvirus genus, specifically variola virus, which causes smallpox, and monkeypox virus. Historically, variola virus, the agent of smallpox, can be transmitted by both respiratory droplets and direct contact.
Both routes. Wow.
Yes, that dual mode of transmission explains its devastating epidemic potential and why it was such a global threat, claiming millions upon millions of lives before its eradication.
That makes perfect sense for smallpox, explaining its historical devastation. But were there any instances of its transmission that truly shocked experts, even as it was being pushed towards eradication? Like a final, scary demonstration of its danger?
There was indeed. A very rare and frankly concerning instance near the very end of the global eradication efforts. It truly underscored its danger and the constant vigilance required. It was a reported case of aerosol transmission in a German hospital in Machida.
Aerosol. So airborne, not just droplets.
It's exactly. Far from any typical contact scenario. This was airborne spread, highlighting the virus's historical capacity for unusual and incredibly dangerous dissemination, even as it was being pushed to the brink of extinction worldwide. It was a stark reminder of just how potent it was.
Chilling. And monkeypox. It's been in the news more recently, sometimes causing quite a stir. How does its transmission compare to smallpox, and what makes it a growing concern today?
Monkeypox virus is fascinating in its epidemiology. It's thought to be primarily transmitted to humans through handling of, or other direct contact with, infected animals. This leads to percutaneous or permucosal exposure, basically, getting it through breaks in the skin or through mucous membranes like your eyes, nose, or mouth.
So contact with infected animals is the main starting point.
Often, yes. That's why activities like hunting or preparing African wildlife for food are well-known risk factors for acquiring it in endemic regions. However, and this is the really significant part, once it enters human populations, it can then spread between humans by both respiratory and contact routes.
So it has that dual capability too once it's in people.
It does. And that's crucial for its potential for onward transmission within communities. And stepping back for a moment, looking at the bigger picture, we've seen rising numbers of monkeypox cases reported from endemic countries in Western and Central Africa. Places like Nigeria, Cameroon, the Central African Republic, the DRC over the past 5 years or so.
A noticeable increase.
Definitely. In some instances, these are even the first national reports of the disease, since it was initially identified in humans way back in the late 1970s and 1980s. Now, while these increases could certainly be partly due to better surveillance, we're looking harder.
We're finding more because we're looking more.
That's part of it, likely. But there's a deeper concern. A recent modeling study, sponsored by the WHO, looked very closely at the effective reproductive rate, or R0, of monkeypox.
R0, that's how many people one infected person passes it on to, on average.
Exactly. And this study's finding was quite striking. It suggested that monkeypox may now be capable of spreading epidemically through human interactions alone, meaning it wouldn't necessarily require repeated exposures to infected wildlife to keep outbreaks going.
Whoa, that's a big shift from previous understanding, right?
It is. This observation is particularly important because it stands in direct contrast to findings from earlier WHO-sponsored studies. It suggests a potentially evolving and frankly more concerning epidemiological profile for the virus. It hints that something might be changing.
So, if I'm understanding this, it's not just that we're looking harder. There might be something fundamental changing about the virus's ability to spread between people. What does this all mean for us? Is there a reason why we might be seeing more outbreaks now, beyond just better surveillance? What could be driving this potential shift?
That's a critical point, and it begs the question, what's behind this apparent shift? Well, this potential for increased human-to-human spread may be partly attributed to waning immunity from the smallpox vaccine, the vaccinia vaccine.
Because we stopped routine smallpox vaccination after it was eradicated.
Precisely. As smallpox was eradicated through that monumental global effort, routine vaccination with vaccinia virus largely ceased worldwide. Over time, this has led to a larger and larger susceptible human population, people with less or even no protective immunity against orthopoxviruses like monkeypox.
So the shield we had is lowering.
In a sense, yes. It highlights this delicate but profound balance in public health and vaccine-derived immunity. When a disease is gone, the protective shield against related threats, which the original vaccine also conferred, can unfortunately diminish over generations. It's an unintended consequence of success that requires ongoing vigilance.
That's a crucial point, a really thought-provoking long-term consequence. So what about the other poxviruses we mentioned? How do they typically spread? They don't seem to follow these same alarming patterns as smallpox or monkeypox, right?
Right. Most other orthopoxviruses, the ones identified in our sources table 196-1, they're thought to spread only via direct contact or percutaneous permucosal exposures to infected animals.
Through the skin or mucous membranes again.
Exactly. Sometimes they can also spread from human to human by direct contact with lesions, but that's generally less common than the initial animal-to-human jump. Now, Molluscum contagiosum virus, MCV, which is incredibly common worldwide.
I think a lot of parents listening might know that one.
Very likely. It probably spreads through direct contact with and percutaneous exposure to another infected human. Unlike variola or monkeypox with their animal links, MCV is considered to be a pathogen of humans only.
No animal reservoir.
Not really, no. Its spread is essentially human-driven. The epidemiology of tanapox, interestingly, is still poorly understood. Simian, non-human primate, reservoirs are postulated, monkeys or apes might harbor it, and there's even a hypothesis for potential vector-borne infection.
Meaning an insect could transmit it, like a mosquito.
Possibly, yeah. An insect vector is hypothesized, which adds a layer of mystery to its specific transmission pathways. That would be quite different. Finally, human infections with parapoxviruses. They occur through direct contact with and percutaneous exposure to lesions developing at the site of contact, often from infected livestock, sheep, goats, cattle.
So mostly contact, except for those big exceptions.
That's the general rule. Monkeypox and variola stand out for their respiratory potential, but contact with animals or infected human lesions remains the most common route for the vast majority. And that gives us clear avenues for prevention, focusing on barriers and hygiene.
Okay, here's where it gets really interesting for anyone wanting to truly master this topic, to get that professional level grasp. Our source material, Chapter 196, gives us that detailed table 196 to 1. It's almost like a family tree for these viruses.
It's a fantastic resource.
Yeah, it offers a quick reference to this diverse world of poxviruses that can infect humans. Instead of just listing them, let's unpack the key players. Their origins, their geography, what makes each genus, and maybe a few standout species within them unique. This is about grasping the patterns, right?
Absolutely. This table is incredibly valuable because it quickly highlights the geographic spread, the zoonotic characteristics, the unique features of each species. It's a great snapshot for understanding the diversity within this viral family. It makes it easier to grasp not just what they are, but where they typically come from and how they generally interact with us. Let's maybe start with the broad families, the genera.
Okay, let's start with the orthopoxvirus genus, often considered the classic poxviruses, right? Since smallpox belongs here, what's the essential takeaway for this group?
The orthopoxviruses are definitely a historically significant group and still very relevant. First, of course, there's variola, the virus behind smallpox. Historically, it was worldwide, but crucially, it's eradicated. A monumental triumph of global health, really showing what can be done. And key to that was it being solely a human pathogen. No animal reservoir to hide in.
Made it targetable.
Exactly.
Yeah.
Then monkeypox, found primarily in Central and Western Africa, but as we discussed, it's been exported globally multiple times. That highlights our interconnected world. Its zoonotic characteristics are quite complex. It involves a range of African rodents, squirrel species, Gambian rats, dormice. They're implicated as potential reservoir species. They harbor the virus, maybe without getting severely ill themselves.
So they keep it circulating.
Right. And other species have also been effective in transmitting it to humans. Notably, pet North American prairie dogs caused that outbreak in the U.S. a while back. It can also be acquired by humans during hunting or preparing African wildlife for food. A clear human-animal interface risk. Then we have cowpox, found mainly in Europe. Now, its primary reservoirs are wild rodents, not cows, despite the name.
Ah, that's confusing.
It is. We've seen outbreaks associated with the rodent pet trade, like pet rats. That shows how human practices can spread these viruses. Interestingly, cats are also effective transmitters to humans. They often pick it up from rodents and then pass it to their owners.
So watch out for sick cats if you're in Europe.
It's a known route, yeah. Historically, dairy cow teat lesions were linked to human skin lesions, which is where the name came from. It reflects that historical observation on livestock, even though rodents are the true reservoir. Next, vaccinia and vaccinia-like viruses. Examples are buffalo pox, Contagiosum, Aracituba. These are found in India and South America. Rodents are suspected as potential reservoirs here too, similar to cowpox. Localized lesions on cattle or other ruminants, like water buffalo for buffalo pox, are responsible for most human infections through direct contact. And this is important because vaccinia is the virus that was used for the smallpox vaccines.
Right, the vaccine virus.
Exactly. But it also circulates as a natural virus in certain animal populations, presenting its own unique risks, especially to people working with those animals. And then there are the more recently identified orthopox viruses, AK 2015, found in the U.S., specifically Alaska. Its zoonotic site is still under investigation. Shows discovery is ongoing.
Still finding new ones.
We are. And Aklida, from Georgia, the country. That one's been identified with wood mice, specifically Apidemus species, as a reservoir. These new identifications really demonstrate that the orthopox virus family is still revealing new members and new transmission pathways. The viral world is constantly shifting.
That's a really comprehensive look at the orthopox viruses. Definitely highlights their animal origins and different geographic footprints. So what about the other genera? Are there clear takeaways for them too?
Yes, let's move on. Molluscum virus. Here we primarily focus on Molluscum contagiosum virus, MCV, found worldwide. This one is generally thought to be solely a human pathogen.
So humans are its main host, maybe its only host.
That's the general thinking, yes, making it distinct from many others we've discussed. However, it's worth noting, Closely related viruses have been described in other mammals. It suggests maybe a deeper evolutionary connection, or perhaps a broader host range than we fully understand, even if human-to-human spread is dominant now. Next, the Poxvirus genus, often referred to collectively as the ORF viruses.
Orf.
Yes, ORF. The species ORF itself is found worldwide. A crucial takeaway here is its strong link to livestock. Handling infected sheep and goats is primarily responsible for transmission to humans. Makes it an occupational hazard for farmers, vets.
People working closely with those animals.
Exactly. And the question of fomite transmission spread via inanimate objects like tools, fences, clothing that's also raised suggests indirect contact might play a role too. Then there's pseudo-cowpox, also worldwide, primarily transmitted through handling infected dairy cattle. And like ORF, fomite transmission is also a possibility. Bovine papular stomatitis, another worldwide parapoxvirus, usually acquired from handling infected beef cattle. So you see the pattern for parapoxviruses, a very close connection to livestock.
Definitely a pattern there. Sheep, goats, cattle.
And it broadens further. We have deerpox, found in U.S. deer herds, transmitted through handling infected deer, and sealpox, which affects seal and pinniped colonies worldwide. Human infections occur through handling infected pinnipeds, seals, sea lions.
Seals too, wow.
Yeah. It truly demonstrates the broad range of animal hosts that can harbor these viruses and transmit them to humans, usually through direct contact.
Fascinating how diverse those animal connections are. Feels like every corner of the animal kingdom has its own poxvirus. What about the last classified genus mentioned? Is there a unique pattern there?
That would be Poxvirus. With Tanapox is the key species we know infects humans. It's found in Africa. A possible non-human primate reservoir is postulated, aligning with what I mentioned earlier about potential simian involvement, and that intriguing hypothesis of vector transmission.
The insect possibility again.
Right, perhaps an insect could play a role in its spread. That would make it quite unique among the poxviruses we've covered, which mostly rely on direct contact. Still needs more research. Finally, we have that unclassified poxvirus, known as NY013, identified in the U.S., New York State, its zoonotic characteristics. Unknown currently. Possibly an orthopoxvirus. Still under investigation.
Still more questions than answers for that one.
Exactly. It just emphasizes the continuous discovery of new viral agents and the dynamic nature of virology. The landscape is always changing. We haven't found them all yet.
That's quite the rogues gallery. And it really, really highlights how interconnected human health is with animal health and even our environment. It's not just about what's circulating in other people, it's often about what's out there in the natural world. Mastering this field means understanding these complex ecologies.
Indeed. It's a clear reminder that human activities, agriculture, pet ownership, hunting, even urbanization, encroaching on wildlife habitats can directly influence our exposure to these viruses. Yeah. It's a constant dance, a constant interaction between us and the microbial world around us.
Okay, so we've dissected their genetic makeup and charted their family tree, which gives them their unique abilities and spread strategies. Now, let's see how those abilities translate into actual infection. Once these viruses get into the body, what happens next? How do they actually cause disease? And what does it look like when someone gets sick? This is the pathogenesis part, right?
Exactly. Pathogenesis, the process by which infection leads to disease. And if we connect this to the bigger picture, understanding pathogenesis helps us predict, manage, and ideally prevent severe outcomes. The way these viruses interact with our immune system is absolutely critical to how severe an infection becomes. Let's start with the pathogenesis of orthopoxvirus infections, like smallpox and monkeypox, which tend to be systemic.
Systemic, meaning they spread throughout the body, correct? It's not just a localized skin thing. And how does that journey typically begin? Where do they first set up shop?
Precisely. It's a journey through the body, not just localized. The process usually begins when the virus first enters and starts replicating at the site of initial inoculation. That's the point of entry. Could be a tiny skin break, could be the lining of your respiratory tract. From there, it typically spreads to regional lymph nodes. These are key immune hubs, acting as a sort of staging ground or initial checkpoint for the virus.
The lymph nodes try to fight it off there.
They do, yes.
Yeah.
That's where the initial immune response really kicks in. From these lymph nodes, if the virus isn't contained, it enters the bloodstream. This leads to what we call a primary viremia.
Viremia, virus in the blood.
Right. In this primary viremia, early internal organs get seeded with a relatively low level of virus. Then, after this initial phase, a second, much more robust phase of viremia follows. The virus replicates to much higher levels in those initial organs. This secondary viremia leads to widespread seeding of internal organs throughout the body. causing more generalized symptoms like fever, aches.
Feeling really sick systemically.
Exactly. And finally, this symptomatic febrile viremia virus in the blood, accompanied by fever, seeds the skin. That's when the characteristic rash begins to appear.
Ah, so the visible rash is actually one of the later stages of this whole systemic spread. It's not where the infection starts. How does our immune system play into the severity of this journey? Is it the key determinant of whether someone gets really sick or just mildly ill?
It's absolutely a key determinant. You could say it's the primary gatekeeper, or maybe the battlefield commander. The severity of the disease is directly affected by how well the innate immune system, our body's immediate non-specific defenses, and especially our interferon responses, control these initial stages of infection.
Interferons, those are like the body's alarm signals against viruses.
Exactly. They interfere with viral replication. A robust early immune response, particularly a strong interferon response, can significantly limit the viral spread throughout the body. It can really damp down that secondary viremia and thus dramatically reduce the severity of the illness. This is where individual immune differences become really apparent.
That makes perfect sense. But what happens when that immune system isn't functioning optimally in immunocompromised individuals? I imagine the picture changes dramatically for them, and this is critical for professionals to understand.
That's a critical consideration, yes. And the picture changes quite dramatically, often tragically. In immunocompromised persons, we often see much more severe and protracted forms of the disease. Their immune system simply cannot effectively keep the virus in check. A classic, well-studied example involves the adverse events associated with smallpox vaccination using the live vaccinia virus. For individuals with intact, healthy immune systems, vaccination typically results in just a localized lesion at the inoculation site. Appears about 3-4 days post-vaccination. This lesion then progresses, becomes vesicular like a small blister, and then pustular, filled with pus, around 7-10 days. Sometimes you get localized symptoms like lymphangitis inflammation, tracking up the arm-swollen lymph nodes, lymphadenopathy, maybe a mild fever. After about 14 days, the lesion starts to scab over. That indicates a contained, expected immune response. It's a sign the vaccine has taken.
But the picture changes drastically for those with pre-existing conditions or weakened immune systems, right? What kind of severe reactions can they experience? That must be a major concern.
A major concern, yes. For instance, persons with atopic dermatitis or eczema, those chronic inflammatory skin conditions, they can develop something called eczema vaccinatum. This isn't just a local lesion. It's a widespread and severe rash that spreads far beyond the vaccination site, sometimes covering large areas of the body, becoming incredibly painful and potentially life-threatening. And for those with general immunosuppression or immunocompromise, perhaps due to HIV, cancer treatment, or organ transplants, they can develop progressive vaccinia, also called vaccinia necrosum. In these cases, the virus's spread or growth just goes unchecked.
The immune system can't stop it at all.
Essentially, no. It can lead either to systemic spread of the disease throughout the body or a progressive, relentless, non-inflammatory growth of the original lesion itself, which can become quite large, necrotic, and destructive. Even in HIV patients, generalized vaccinia with widespread rash dissemination has been documented. It's vital for clinicians to distinguish these true viral disseminations from just inflammatory rashes, which can sometimes look similar but are less severe.
That truly underscores the immune system's role as the ultimate arbiter of disease severity.
Wow. What about the other poxvirus infections we mentioned, like Molluscum contagiosum or the Poxviruses? Do they follow this same systemic pattern, or are they generally different?
Generally different, thankfully, with the possible exception of Poxvirus infection, where the pathogenesis is still poorly understood and you have that vector theory.
The insect bite idea.
Right. Most other infections, like MCV or parapoxviruses, likely involve only local growth of the virus at the site of inoculation or maybe reinoculation. They stay put.
So they don't typically go systemic.
Not typically, no. This explains why they don't usually cause systemic illness or widespread rash. They remain contained to the skin where they entered. However, even with these localized infections, the immune system remains paramount. In some immunocompromised hosts, for example, the lesions caused by parapoxvirus infections can become unusually large, leading to what's referred to as giant ORF.
Giant ORF. That sounds unpleasant. It can be quite disfiguring and difficult to treat. So again, it underscores the immune system's critical role in containing even what are usually localized and self-limiting infections. It's all about how well our defenses hold the line, whether it's a systemic or local invader.
So the immune system is really the gatekeeper here. And if it's compromised, even typically localized infections can become much more serious. This brings us logically to how clinicians approach a patient who might have one of these infections. What are the first things they look for? What's the initial assessment like for someone presenting with suspicious lesions?
That's a crucial question for anyone in the medical field, from primary care to specialists. Clinicians need a systematic approach. Patients usually present with nodular or vesicular-pustular lesions. Those bumps or fluid-filled sores are often the most obvious sign. But the patient's history, it's absolutely crucial for diagnosis. Arguably even more so than just the physical exam itself sometimes. It fills in the critical context.
What specific elements of a patient's history are most helpful? What kinds of questions are clinicians asking to really narrow down the possibilities and get towards that accurate diagnosis?
Key history elements include um, recent travel history. They traveled to an endemic area.
Yeah.
Africa for potential monkeypox, Europe for cowpox. Even just local contact exposures are important. Occupation is also a significant factor. Certain jobs carry higher risk.
Like we discussed with the table lab workers, farmers.
Exactly. Lab workers handling vaccinia, farmers encountering parapoxviruses from livestock, hunters exposed to monkeypox from wildlife, even healthcare workers due to potential human-to-human transmission in some cases. Clinicians also ask about how the lesions have developed and changed over time, the progression of the rash. That pattern can be very indicative, especially for orthopoxviruses. And finally, the temporal relationship between fever and rash onset is highly suggestive. In systemic infections like smallpox or monkeypox, fever typically precedes the rash by several days. That's a powerful diagnostic clue. If the rash comes first or there's no fever, you might think more along the lines of a localized infection like MCV or ORF.
Beyond diagnosis, what immediate precautions are necessary when a clinician suspects a poxvirus infection? This is critical for safety, right? Are there specific isolation protocols they need to follow immediately?
Absolutely. Patient and staff safety are paramount. During the patient's assessment, contact precautions should always be used when examining patients with suspected poxvirus lesions, as most are spread by direct contact with those sores or contaminated materials.
So, gloves, gown, hand hygiene, the basics.
Basics, but rigorously applied. Critically, though, if monkeypox or smallpox is being considered because of their potential for broader spread, then respiratory precautions, including the use of a negative pressure isolation room if available, are essential.
Because of that aerosol or droplet risk?
Exactly. Because of the known risk of aerosol or droplet transmission for these particular orthopoxviruses, this dual approach of contact and respiratory precautions is vital for containing potential spread in a clinical setting, especially early on before you have a definitive diagnosis.
Now let's get into the visual aspect. What do these infections actually look like? Are there classic appearances that serve as telltale signs for a clinician, almost like a visual fingerprint? Because seeing it or imagining it clearly often helps solidify the understanding for those trying to master this.
Absolutely. Visual recognition is key for clinicians, and the clinical manifestations can be quite distinct, especially for the systemic infections. For systemic orthopoxvirus infections, specifically smallpox and monkeypox, the first clinical sign is usually that fever, which importantly precedes the onset of the rash by several days. The rash itself then evolves through that classic progression of distinct phases we need to know. It starts as macular, flat, discolored spots, then becomes papular, small, solid, raised bumps, then vesicular fluid-filled blisters, and finally pustular pus-filled lesions.
Flat spots, raised bumps, blisters, then pus-filled sores. Got it.
And a key distinguishing feature of the pustules, especially for orthopoxviruses, is that they often develop umbilication. That's a central depression, almost like a little belly button on top. It's a very specific and helpful diagnostic sign. You don't see that with everything.
The umbilication, that little dimple, is a potential dead giveaway, right? Is there also a typical pattern to where these lesions appear on the body? Does it spread randomly, or is there a specific distribution pattern that's characteristic?
You've got the progression perfectly. And yes, the distribution is another crucial tell. Very characteristic for orthopoxviruses. They exhibit a centrifugal distribution.
Centrifugal, meaning away from the center. Some more on the arms and legs.
Exactly. Lesions are more prominent on the extremities, the arms, legs, hands, and feet, than on the trunk of the body. This is a very strong diagnostic clue. Furthermore, lesions are often particularly prominent on the palms of the hands and the soles of the feet, and also the face.
Palms and soles, that's unusual for many rashes, isn't it?
Very unusual, and therefore a very powerful indicator for clinicians trying to differentiate, say, smallpox or monkeypox from other rashes like chickenpox, which tends to be more central. As the disease progresses, a secondary or even tertiary fever can develop. That tertiary fever is sometimes a hallmark of bacterial superinfection of the lesions, which is a common and serious complication needing antibiotics. And it's also important for isolation protocols to know. Once the lesions scab over and the scabs separate cleanly from the skin, the patient is generally no longer infectious. That guides when isolation can safely be lifted. Figure 196 to 1 of the source material, for example, illustrates this beautifully. It shows the characteristic maculopapular monkeypox rash on a young boy in the DRC. Strikingly similar in appearance to historical smallpox cases, it's truly a classic presentation professionals need to recognize.
That visual description and the centrifugal pattern, plus palms and soles, that really help solidify the classic orthopox presentation. What about other pox viruses? Do they also cause widespread rashes like that, or do they have different patterns we should know?
Not all of them follow that pattern. For instance, patients infected with Poxvirus virus initially present with a very high fever. This often leads to misdiagnosis as malaria, especially in endemic regions of Africa where malaria is so common. Only later do they develop a much more limited number, typically just 1 to 10 nodular lesions, firm bumps, not the typical pustules, and distinct from the generalized rash of orthopox viruses. Not widespread at all. Other orthopox virus infections, like those caused by Acmeta, AK2015, vaccinia, and cowpox viruses, they're generally more localized in their presentation, at least in healthy people. They're typically associated with a localized rash or lesion developing directly at the site of contact with the virus.
So where you touched the infected animal or material?
Usually, yes. However, it's worth reiterating. In immunocompromised patients, the presentation of these otherwise localized orthopox virus infections can become protracted or even disseminated. More widespread and severe because the body can't contain them effectively. Immune status is always key.
And what about the ones that only cause localized disease, like Molluscum contagiosum or the parapox viruses? What's their typical presentation? Less dramatic, I assume.
Generally less dramatic systemically, yes. For individuals infected with other pox viruses that cause localized disease, like parapox viruses and MCV, they seldom report a febrile phase. Systemic symptoms are generally absent. You won't typically see a fever or body aches. Instead, patients usually notice the slow and gradual development of a single nodular papular lesion or maybe a small cluster of lesions. The lesion of Molluscum contagiosum had that classic pearly or flesh-colored appearance, often with the distinctive central umbilication as it matures. They are typically painless and usually don't have an obvious inflammatory response, no redness or swelling around them. That helps distinguish them from, say, bacterial infections.
They just sort of appear.
Yep, they often do, yes. And they persist, but generally regress gradually on their own after 6-12 months in healthy individuals. However, as with other pox viruses, giant parapox virus infections where the lesions become unusually large and disfiguring have been reported in immunocompromised individuals. Again, showing the profound impact of immune status on even seemingly benign infections.
Given all these varied presentations, from widespread pustules to single pearly bumps, it sounds like some could easily be mistaken for other, more common skin conditions. What's the differential diagnosis a clinician has to consider when they see a suspicious rash? What are the common lookalikes they need to rule out?
That's a crucial point for clinical practice, absolutely. The presentation of poxvirus infections can indeed be confused with other conditions. The differential diagnosis includes, for example, varicella or chickenpox.
Chickenpox is probably the most common confusion.
It often is, especially with orthopox viruses. But while both cause vesicular rashes, varicella has a different rash evolution. It appears in crops of lesions at different stages simultaneously. And typically a centripetal distribution, more lesions on the trunk than the extremities. Opposite to orthopox viruses. Centripetal versus centrifugal. Key difference. Key difference. Other considerations include yaws, a chronic bacterial infection causing skin lesions, often confused in tropical regions, and papillomavirus infections, which cause warts. These might initially resemble some poxvirus lesions, but the classic umbilication of MCV, for instance, often helps differentiate it from papillomavirus warts, which usually lack that feature. So a keen eye, a thorough patient history including travel, animal exposure, vaccination status, and understanding these patterns of rash progression and distribution are crucial for an accurate clinical diagnosis, especially before you get definitive lab confirmation.
It really sounds like a keen eye, and that thorough patient history are absolutely crucial. But when it comes to confirming these infections definitively, what's happening in the lab? How do we identify these viruses when clinical signs aren't enough? Or we need absolute certainty? Because that's where the elite professionals truly get the definitive answer.
You're right, laboratory confirmation is often the definitive step, especially for public health tracking or managing severe cases. And advances in molecular diagnostics have truly transformed our ability to detect and characterize poxviruses. They offer a level of precision and speed that older methods sometimes lacked. It's really been a game changer.
What's considered the gold standard in the lab today for identifying these viruses? What's the go-to test?
Currently, the most common and powerful laboratory tool for diagnosing poxvirus infections involves nucleic acid testing. And the gold standard within this is polymerase chain reaction, or PCR.
PCR, which we hear about a lot these days.
Exactly. This technique works by amplifying tiny amounts of viral DNA present in a sample, like from a lesion, scraping, or scab. It allows for highly sensitive detection even when there's very little virus present. It's like finding a single needle in a haystack by making millions of copies of it so it's easy to see. In some cases, to fully characterize the isolate, maybe to get a precise identity, understand the specific viral strain for epidemiological tracking, or see if it has resistance markers, sequencing is used after PCR. This combination of PCR and sequencing has been instrumental in identifying those newly recognized human infecting poxviruses, like Acmeta, AK2015, and NY014. It shows its power in ongoing discovery and surveillance.
So molecular methods are clearly key, the most precise tools. But what about older, more traditional methods, like trying to grow the virus in a lab? Is viral culture still useful, or has it been entirely replaced by PCR?
Viral culture is still used, but its utility really varies depending on the specific poxvirus you're dealing with. Orthopoxviruses, for instance, like vaccinia or monkeypox, they grow quite well in most standard clinical laboratory tissue cultures. That makes them relatively easy to isolate and study further in a lab setting if needed. However, parapoxviruses, they're quite difficult to isolate via culture. Primary cells are the preferred method, but it's still challenging and not routinely done in most clinical labs. And notably, Molluscum contagiosum virus, MCV. It cannot be cultured at all in standard lab settings using current techniques.
Can't grow MCV in the lab at all.
Nope, which makes molecular methods like PCR even more vital for its definitive diagnosis, beyond just clinical appearance or biopsy. So viral culture is a mix, highly useful for some poxviruses, impractical or impossible for others.
Are there any other visual ways to identify them in the lab, perhaps looking at the virus particles themselves with really powerful microscopes, like electron microscopy?
Yes, electron microscopy, or EM, is another method. It's particularly useful for a quick morphological identification, looking at the shape and structure. It identifies the characteristic morphology of virus particles using a technique called negative staining. Orthopoxvirus, Poxvirus, or MCV particles, they appear as distinctively large, brick-shaped virus particles under the electron microscope. It's quite a classic look. Parapoxviruses, interestingly, have a unique identifying feature. An ovoid or egg-like structure with distinct crisscross spicules, like threads wound around them, on their surface. It's a very specific visual signature for that genus visible with EM.
Brick-shaped versus ovoid with crisscrosses. Okay. And for MCV specifically, you mentioned biopsy. Is there a unique histological finding, something a pathologist would look for in that tissue sample under a regular microscope?
Absolutely. For MCV, pathologic analysis of a biopsy sample from one of those pearly lesions shows a classic appearance with distinct Henderson-Patterson bodies.
Henderson-Patterson bodies.
Yes. These are large eosinophilic, meaning they stain pink with a common dye called eosin intracytoplasmic inclusions within the infected skin cells. They are a hallmark for diagnosis, very specific to MCV, and essentially represent massive accumulations of viral factories and particles within the cell's cytoplasm. Seeing those confirms MCV histologically.
Finally, what about blood tests? Looking for antibodies, serology, can they tell us if someone has been infected with a poxvirus? Are they useful for diagnosis?
Serologic assays can indeed be used. They can demonstrate orthopoxvirus reactivity, meaning they can tell you if someone has antibodies to an orthopoxvirus, indicating a past or recent exposure or infection. However, and this is a significant limitation for precise diagnosis, most current serologic assays are unable to distinguish between different orthopoxvirus species.
Why is that?
It's because of their broad antigenic similarity. Essentially, the proteins on the outside of viruses like vaccinia, monkeypox, cowpox, they look too much alike to the immune system at the antibody level. They cross-react heavily.
So the antibody test says orthopoxvirus, but not which orthopoxvirus.
Exactly. It means while you can confirm an orthopoxvirus exposure or infection happened, You might not know if it was vaccinia from a vaccine or monkeypox or cowpox based on serology alone. For precise species identification, you generally need nucleic acid testing like PCR or sequencing, so serology tells you an orthopoxvirus was here, but not always which specific one it was. Useful for population studies, less so for diagnosing an individual's current specific infection.
Okay, that makes sense. So while some older methods like EM or biopsy have their place, and serology gives exposure info, nucleic acid testing, PCR is really the game changer for precise identification and epidemiological tracking. Now, once a diagnosis is made, what's the treatment plan? For many viral infections, treatment is often just supportive care managing symptoms. Is that the case for poxviruses, or do we have specific tools in our arsenal, especially for the more severe ones like monkeypox or smallpox?
That brings up a critical point for managing patients. How do we intervene and what are our options? You're right, the treatment of many viral infections is largely supportive, aiming primarily to alleviate symptoms like fever and pain, and crucially, to prevent complications like secondary bacterial infections and skin lesions. That remains a cornerstone for poxviruses too. However, for orthopoxviruses specifically, we now have specific antiviral agents available. This represents a significant development and gives us more direct tools against these particular threats, moving beyond just managing symptoms. This is where modern antiviral medicine really steps in, offering targeted therapies.
Okay, let's talk about those specific antivirals for orthopoxviruses. What are they and how do they work? What do professionals need to know about using them?
The first one, and perhaps the most well-known currently, is TPOXX. The generic name is ticovirimat. This drug has been approved by the U.S. Food and Drug Administration, the FDA, specifically for the treatment of smallpox.
Approved for smallpox, even though it's eradicated.
Yes, partly as a biodefense preparedness measure, but its approval signifies its effectiveness against that prototypic orthopoxvirus. Beyond smallpox, it has also been used investigationally under special protocols to treat isolated cases of vaccinivirus infection, particularly those severe adverse reactions to smallpox vaccination or accidental laboratory exposures. And importantly, it's being used for monkeypox too.
Okay, so TPOXX, tecovirimat, how is it given?
For adults, the recommended dosage is 600 milligrams taken orally, twice daily, for 14 days. An important practical detail for patient compliance and optimal efficacy is that its bioavailability, how much gets absorbed, is best if taken with a fatty meal.
Take it with food, especially fatty food.
Yes, it's a fat-soluble drug, so it's absorbed better with fats. That's key for it to work well. It works by targeting a specific viral protein, VP37, which is necessary for the virus to wrap itself properly and spread effectively from cell to cell, so it stops the spread within the body. Another important agent is vaccinia immune globulin, or VIG. This isn't a drug in the typical sense, it's a biological product. Essentially, it's a concentrated form of antibodies collected from the plasma of individuals recently vaccinated against smallpox.
So, borrowed immunity.
Exactly. It's licensed for the treatment of certain severe adverse reactions to the smallpox vaccinia virus vaccine, especially for life-threatening cases like progressive vaccinia or eczema vaccinatum. The standard dose is quite high, 6,000 units per kilogram of body weight, given intravenously, and dosing can be repeated, with some cases requiring up to 9,000 units per kilogram, depending on the severity and response. And more recently, a newer antiviral drug, brincidofovir, with the trade name Tembexa, was approved by the FDA for the treatment of smallpox in June 2021. This further expands our treatment options. It's a lipid conjugate of cidofovir, another antiviral, designed for better oral bioavailability and cellular uptake. It works differently than TPOXX. It interferes with viral DNA replication.
So now there are multiple drug options for smallpox and by extension, potentially other orthopoxviruses.
Yes, having multiple options with different mechanisms is very valuable. And beyond these established treatments, research is very active. Cutting-edge approaches like cocktails of specific monoclonal antibodies are also being assessed in clinical trials. This indicates ongoing development to find even more effective and targeted treatments against orthopoxviruses.
So for the serious orthopoxviruses, we have some targeted treatments, which is great news. What about Molluscum contagiosum? You mentioned it's quite common, but usually localized. Do we have specific drugs for that, or is it managed differently? Do we even need to treat it?
For Molluscum contagiosum virus, or MCV, treatment is approached quite differently, really on a case-by-case basis. It's primarily considered if quicker resolution is desired by the patient or parents.
Why only if quicker resolution is desired?
Because unlike the more severe orthopoxviruses, MCV typically resolves spontaneously over time, usually within 6 to 12 months, sometimes longer. as the body's immune system eventually recognizes and clears it in healthy individuals. It just takes time. However, if a patient wants faster clearance, maybe for cosmetic reasons, to prevent spread to other children in a household or school, or if the lesions are causing itching or irritation, or various methods have been investigated and are commonly used. These include physical methods like curettage, which basically involves scraping off the lesions with a small spoon-shaped instrument, or topical liquid nitrogen, known as cryotherapy, which freezes them off. Some topical agents that cause blistering, like cantharidin, are also used sometimes. And certain immunomodulators, like imiquimod cream, have been explored for topical application to try and stimulate a local immune response against the virus, although evidence for effectiveness is mixed. There's no single FDA-approved antiviral drug specifically for MCV.
So, mostly physical removal or waiting it out for MCV. While we're getting better at treating these, what are the most serious complications we need to be aware of across the poxvirus family? What are the potential long-term consequences professionals need to watch for?
Stepping back for a moment, knowing the potential complications allows for proactive monitoring and timely intervention, which can prevent significant long-term harm. Ocular involvement infection of the eye is a particularly significant concern across the poxvirus spectrum, but especially with orthopoxviruses like vaccinia, cowpox, and monkeypox, if lesions are near the face.
Eye infections, how serious can those be?
They can be very serious. Infections can often seed tissues around or in the eye, leading to keratitis, which is inflammation of the cornea, the clear front part of the eye. This can cause pain, light sensitivity, blurred vision, and potentially severe corneal scarring. The critical risk here is that these infections, if left untreated or if they're very severe, can ultimately lead to permanent vision impairment or even blindness. It emphasizes the absolute need for careful observation and immediate ophthalmologic consultation if eye involvement is suspected.
Blindness is a devastating outcome. Is there specific treatment for these eye infections?
Yes, thankfully. For specific treatment of these ocular infections caused by poxviruses, topical antiviral agents like trifluridine eye drops are typically used. Prompt treatment is crucial to prevent scarring and vision loss.
That's a really serious potential outcome, losing sight. How does the overall prognosis, the likely outcome, change depending on who gets infected? Are some individuals inherently more at risk for severe outcomes than others? What are the biggest factors that determine how sick someone gets?
That begs an important question about the variability we see in disease outcomes. And the answer is clear. The patient's immune status is undoubtedly the biggest determinant of prognosis for almost all poxvirus infections. It almost overshadows all other factors. For immunocompetent host people with healthy, fully functioning immune systems, most poxvirus infections like MCV, ORF, cowpox, and healthy folks are generally self-limited. They resolve without specific antiviral treatment and lead to full recovery, maybe leaving a small scar. The notable exceptions to this rule, even in generally healthy people, are the generalized orthopoxvirus infections caused by monkeypox virus and, historically, variola-virus. These have had significant case fatality rates, ranging historically from maybe 2% up to 30% or more for smallpox, depending on the strain. For monkeypox, it's generally lower, maybe 1-10%, but still significant. This wide range reflects factors like the specific viral strain, the patient's age. Young children often fare worse, and critically, their access to timely and effective medical care and supportive treatment.
And for those with compromised immune systems, we touched on this with vaccine reactions, but how does their prognosis differ for natural infections?
Immunocompromised hosts, as we've discussed, may experience significantly more severe orthopoxvirus and parapoxvirus infections. This includes those conditions like progressive vaccinia, if exposed, severe disseminated monkeypox, or eczema vaccinatum, if they have eczema and get exposed. They can also present with atypical presentations, such as that giant ORF from parapoxvirus infections, where lesions become unusually large, persistent, and destructive, sometimes requiring surgical removal. For MCV infections, while usually benign and self-resolving in others, they can become diffuse and widespread in immunocompromised persons, sometimes covering vast areas of the body with hundreds or thousands of lesions. It can be quite disfiguring and distressing.
Is there anything specific that helps MCV clear in, say, HIV patients?
Yes, interestingly, in HIV/AIDS patients, effective antiretroviral therapy, or ART, is crucial. Reconstituting the immune system with ART will usually lead to the eventual clearance of MCV infections, even widespread ones. It really demonstrates the power of immune recovery to resolve even long-standing viral issues like that. However, a complex phenomenon can occur. Immune reconstitution inflammatory syndrome, or IRIS, has been associated with recrudescence, a flare-up or recurrence of MCV infections in patients starting ARDS.
So starting treatment makes the MCV temporarily worse.
It can appear that way. It's a complex immune reaction where the newly recovering immune system suddenly recognizes and reacts strongly to the MCD virus that was previously ignored. This causes inflammation around the lesions, paradoxically making them look worse for a time as the immune system gears up to clear the virus. It's usually a sign the immune system is getting stronger, but it can be uncomfortable and needs careful management.
Prevention is always better than cure, especially with infectious diseases. It's a core tenet of public health and critical for professionals in the field. What's our best defense against poxviruses? Both generally through everyday actions and specifically through medical interventions like vaccines.
That's precisely where public health strategies really come into play and where individual actions matter. What's truly effective here is how relatively simple, sensible measures, coupled with specific, highly effective vaccines for some poxviruses, can be in preventing these infections. It underscores the critical importance of well-executed public health strategies at all levels, from individual behavior to national programs.
What are the general rules for preventing exposure, especially for those people we identified as being at higher risk due to their jobs or hobbies?
For general prevention, awareness is the first step. Awareness of occupational risks is paramount for individuals in those high-risk professions we mentioned: lab workers, farmers, veterinarians, hunters, healthcare workers. Understanding the specific risks allows for targeted prevention. Beyond awareness, the institution and consistent use of appropriate barrier precautions is key. Things like consistently wearing gloves, masks when appropriate, like for monkeypox risk, protective clothing, eye protection. These effectively prevent most poxvirus infections, especially those spread primarily by contact with lesions or infected animals or materials. These seemingly simple measures are incredibly powerful in breaking chains of transmission. Good hand hygiene is also critical.
And what about vaccination? Is there a widely available vaccine for poxviruses, or is it primarily for orthopoxviruses, given their historical and ongoing significance with smallpox and monkeypox?
Vaccination is primarily targeted at the orthopoxvirus genus, yes. Vaccination with vaccinia virus, the historical smallpox vaccine, is known to be at least 85% effective against orthopoxvirus infections in general, offering gross protection. During the global efforts to eradicate smallpox, getting a qualified vaccine within the previous 3-5 years was viewed as essentially 100% protective against smallpox itself. That's a testament to its incredible effectiveness and a major reason smallpox could be eradicated.
Did that old vaccine also protect against monkeypox?
Yes, significantly. During monkeypox surveillance efforts in Zaire, now the DRC, back in the 1980s, studies show that smallpox vaccination received 19 years earlier was about 85% protective against developing monkeypox disease among household contacts of monkeypox patients. So even that older vaccine offers substantial cross-protection against monkeypox.
That's impressive efficacy. But given that the old smallpox vaccine isn't routinely administered anymore, and it had those side effect concerns, especially the replicative ones, do we know how long protection lasts from those older vaccines? And are there newer, maybe safer options available now?
That's a key question. The exact duration of efficacy for those older, replicative, vaccinia virus-based vaccines is unclear. Protection likely wanes over decades, which, as we discussed, contributes to the growing susceptible population for orthopoxviruses like monkeypox today. However, there's been a significant advancement with a newer vaccine called JYN-NEOS. This is a non-replicating or replication-deficient orthopoxvirus vaccine. It's based on a modified strain of vaccinia virus, MVA-modified vaccinia ankara.
Non-replicating, what does that mean practically?
It means the virus in the vaccine can enter cells and stimulate an immune response, but it undergoes no more than one round of replication in mammalian cells. It can't spread within the body or cause a productive infection. This makes it much, much safer than the older vaccines.
Safer how? Who can get this one?
It's crucial because it means JYN-NEOS can be safely given to a broader population, including many immunocompromised individuals or people with skin conditions like eczema, for whom the older replication-competent vaccines might have posed a serious risk of disseminated infection or severe reactions. JYN-NEOS has been licensed in the United States for the prevention of both smallpox and monkeypox disease in adults determined to be at high risk.
And does it cause that big sore like the old one?
No, that's another major advantage. This vaccine is also much less reactogenic. It causes fewer side effects, less fever, less malaise, and typically doesn't cause that significant localized pustular lesion that the older smallpox vaccines did. Maybe just some soreness at the injection site. This improvement in safety and tolerability makes JYN-Neos a major and versatile tool in our prevention arsenal against orthopoxviruses today. It's given as a 2-dose series.
That's a significant advancement, a safer, more tolerable, non-replicating vaccine effective against both smallpox and monkeypox. Excellent. Now let's zoom in, as promised, on a few specific poxvirus infections that are particularly important or commonly encountered, really getting into the nuances that clinicians, public health professionals, and anyone striving for that elite understanding would need to know. First up, let's tackle Molluscum contagiosum again, but in more detail.
Okay, Molluscum contagiosum virus, or MCV. As we said, it's likely the most common poxvirus infection seen by practitioners in the United States, perhaps even globally. It's transmitted primarily through direct contact, usually via non-intact skin with minor abrasions, eczema patches, or just compromised barriers. Children are very commonly affected, likely transmitting the disease through close play activities, sharing toys, wrestling, or maybe sharing bath towels or sponges. In HIV or AIDS patients, as we discussed, the disease can be quite severe and widespread, with numerous large lesions, really underscoring the impact of a compromised immune system. Genital involvement can also be seen in adults, often transmitted sexually through skin-to-skin contact.
What does it look like clinically again, and how is it typically diagnosed in practice? Is that umbilication always present?
Clinically, the disease is usually recognized by the development of those flesh-colored or sometimes pearly white papules, small, raised, dome-shaped bumps. As they mature, these often but not always become umbilicated, developing that classic central depression or dimple on top. That umbilication is a key diagnostic feature when present. There's typically little inflammation surrounding the lesions, and they are usually painless, which is why people might ignore them for a while. Diagnosis is most often made clinically based on this classic pearly umbilicated appearance. That really helps differentiate it from common warts caused by papillomavirus, which typically lack that central dimple.
So usually just by looking at it.
Often, yes. But for definitive confirmation, especially in atypical cases or if there's diagnostic uncertainty, skin biopsies of lesions will demonstrate that characteristic pathology, the Henderson-Patterson bodies within the cells, those pink-staining viral inclusions. And PCR tests on lesion scrapings can also be used for definitive confirmation.
And treatment for molluscum, you said case by case. What guides that decision, and what are the main options used? How does it differ for kids versus adults or immunocompromised patients?
Right, treatment is done on a case-by-case basis, primarily if quicker resolution is desired or needed. For example, for cosmetic reasons, to prevent spread to other family members or classmates, or if the lesions are causing significant itching, secondary infection, or are just very numerous and bothersome. Remember, in immunocompetent individuals, MCV typically resolves spontaneously over months to maybe a year or two. Patience is an option. If treatment is pursued, methods include physical destruction or removal, things like curettage, scraping, cryotherapy, freezing of liquid nitrogen, or sometimes topical agents like cantharidin, which causes blistering, or retinoids. Some topical immunomodulatory agents, like imiquimod, have also been tried to stimulate a local immune response, but again, the evidence is mixed.
What about in HIV/AIDS patients with widespread disease?
There, the cornerstone of management is effective antiretroviral therapy, RT. Reconstituting the patient's immune system with RT is usually sufficient to eventually clear the MCV virus, even if it takes time. Local destructive therapies might be used for particularly large or bothersome lesions in the meantime. Prevention focuses on simple barrier precautions, things like avoiding sharing towels, razors, or sponges, and maybe covering lesions with clothing or waterproof bandages can help prevent transmission.
Okay, let's switch focus to monkeypox virus. It certainly garnered a lot of global attention recently. What's its current status globally, roughly speaking, and how do people typically get exposed? Remind us of the key routes.
Monkeypox disease remains endemic, meaning regularly present, in regions of Western and Central Africa. That's its natural home. But critically, it has been exported outside of Africa numerous times in the past 20 years, leading to outbreaks in non-endemic countries, highlighting how easily diseases can travel with global interconnectedness. Exposure leading to both exported and endemic disease has occurred in individuals who've had direct contact with infected animals, especially rodents or primates in Africa, or sometimes infected pets elsewhere. And significantly, exposure also occurs through close contact with or respiratory exposure to other humans who have the disease, particularly during the large multi-country outbreak that started in 2022. That human-to-human spread, often through close, prolonged contact, including intimate contact, became the dominant driver in that outbreak.
What's the typical clinical course for someone infected with monkeypox? Walk us through the symptoms again and the rash progression, hitting the key points professionals need to recognize.
Okay. Infected individuals often first experience a prodrome, initial symptoms like fever, headache, muscle aches, exhaustion, and often swollen lymph nodes, lymphadenopathy, which is actually a feature that can help distinguish it from smallpox historically. This prodrome lasts for several days before the rash appears.
So feeling sick first, then the rash.
Exactly. The rash typically develops 1 to 4 days after the fever starts. It often begins on the face or in the mouth and then spreads to other parts of the body, including the hands, feet, chest, and sometimes the genital or perianal areas. The lesions themselves go through that classic poxvirus evolution. Macules, flat spots, to papules, raised bumps, to vesicles, blisters, to pustules, pustule sores, and then they crust over, scab, and fall off, usually over 2 to 4 weeks. Lesions in one area tend to be at the same stage of development, which is another distinguishing feature.
And the distribution, still centrifugal, palms and soles.
Yes, a centrifugal distribution, more on extremities, is often seen, and involvement of palms and soles is common and characteristic. The number of lesions can vary widely, from just a few to thousands. And again, lesions on the face, especially near the eye, need careful evaluation because conjunctival or corneal involvement can lead to vision loss if not managed properly.
We mentioned mortality before, especially in kids in Africa historically. What about more recent outbreaks with different clades or strains and in different populations?
Mortality has generally been lower in recent outbreaks outside of Africa, particularly with the clade I virus dominant in the 2022 global outbreak, often less than 1%. However, deaths have still occurred, particularly in immunocompromised individuals, like those with advanced HIV. The clade I virus, found more in Central Africa, historically has had a higher case fatality rate, up to 10%. So the specific viral clade and the host's immune status are key factors.
How is monkeypox definitively diagnosed, and what are the specific treatment options used now, particularly under those special protocols in the U.S.?
Diagnosis is best achieved by testing material directly from a lesion fluid from a vesicle or pustule, or crusts from scabs. PCR testing on these samples is the preferred laboratory test. It's highly sensitive and specific for detecting monkeypox virus DNA.
So swab the lesions, send for PCR.
Exactly. For treatment, while there's no drug specifically FDA approved only for monkeypox in the U.S., TPOXX, tecovirimat, is available and recommended for treating monkeypox, especially for people at risk of severe disease or with complications. It's available through the CDC under an expanded access investigational new drug, EAIND protocol, or sometimes commercially depending on availability and indication updates. Brincidofovir, Tembexa and VIG, might also be considered in certain specific severe situations, often in consultation with public health authorities like the CDC. Supportive care remains crucial pain management, hydration, preventing secondary bacterial infections.
And prevention. JYN-Neos is the key vaccine now.
Yes. JYN-Neos is the primary vaccine used for prevention of monkeypox in the U.S. It's FDA licensed specifically for preventing both smallpox and monkeypox disease in high-risk adults. It's offered pre-exposure to certain high-risk groups and post-exposure to contacts of known cases to prevent illness or lessen severity. A Camming 2000, an older-style replicating vaccine, is also available, but used much less often due to its side effect profile and contraindications.
Finally, let's briefly touch upon the other poxvirus infections that affect humans. Remind us how they're typically acquired and if there are any standout features in their rashes that help differentiate them clinically.
Certainly. For most other poxvirus infections, excluding Tanapox maybe, initial acquisition is typically through exposure and direct contact with an infected animal or its lesions. Canapox, as we noted, is rare outside of Africa, mostly seen in travelers. Remember, it causes high fever first, then just a few nodular lesions later, often mistaken for malaria initially. That fever preceding just a few nodules is key. For the orthopox virus infections like cowpox and vaccinia-like viruses like buffpox, typically acquired initially through contact with an infected animal, rodents for cowpox, cattle buffalo for others. Human-to-human transmission can also occur via direct contact with a person's lesion. Remember the Pet Rat Association for cowpox in Europe or dairy workers in South America. And lab workers handling vaccinia. Their lesions follow that classic orthopox progression, papule, vesicle, pustule, crust.
Okay, and the parapox viruses, like
Parapox viruses, orth, pseudocowpox, bovine papular stomatitis, are typically only spread to humans through direct contact with an infected animal's lesions, sheep, goats, cattle. Reinforces their zoonotic contact-based nature. Human to human is thought to be very rare, if it happens at all. Their rash characterization is quite distinct and helpful for diagnosis. Parapoxvirus lesions often begin as red papules, then develop into a characteristic target lesion with concentric rings. Subsequently, they become nodular and often quite firm, sometimes even developing a wart-like, papilloma-like surface. They often weep fluid and can be quite large and slow to heal, especially ORF. That target lesion to nodule wart progression is different from the classic orthopox physical pustule path.
Target lesion to nodule wart. That's a good visual cue for parapox. And how are these other, less common ones diagnosed in the lab and treated? Similar principles.
Yes, laboratory diagnosis can be achieved through scrapings of the rash or the scab, similar to monkeypox. Nucleic acid analyses, like PCR or sequencing on that material, are the common approaches for definitive identification and differentiation. Treatment for most of these, tanapox, parapox, localized orthopox in healthy people, is usually supportive. The main goals are preventing spread to other body parts or people, good wound care to prevent secondary bacterial infection, effective pain management, and just allowing the body's immune system to clear the infection, which it usually does, albeit sometimes slowly for parapox viruses. Specific antivirals aren't typically indicated or available for these, unlike for severe orthopoxvirus disease.
So, what does this all mean for us? Wow. This deep dive into Chapter 196 has truly taken us through the intricate, sometimes alarming, often surprising world of poxviruses. From their unique genetic blueprints and their clever immune evasion tactics, to their diverse clinical presentations and how we diagnose, treat, and prevent them. We've certainly gone deep into the details, hopefully helping you feel closer to mastering this information like the elite professionals in the field.
If we connect this all back to the bigger picture, it profoundly underscores that constant interplay between human activity, animal reservoirs, and global health. The resurgence of monkeypox, the ongoing challenges of managing common localized infections like molluscum, especially in vulnerable populations, and the power of newer, safer vaccines like JYN-Neos. It all tells a compelling story. It's a story of ongoing vigilance, rapid scientific advancement, and the continuous evolution of both the viruses themselves and our strategies to combat them. It's a field that's anything but static. Our understanding and the threats themselves are continuously evolving. This is truly a dynamic area of study and public health action.
Indeed. We've seen how a detailed understanding down to the level of specific genes or lesion appearance can explain vast differences in disease manifestation, and how our immune system is truly our first line of defense, capable of containing some infections but sometimes overwhelmed by others, leading to vastly different outcomes. Knowing these precise details, like the telltale umbilication of molluscum, or the centrifugal rash of monkeypox, or the target lesions of ORF, doesn't just fill in textbook knowledge. It helps us appreciate the incredible precision needed in medical diagnosis and the fascinating, sometimes alarming intricacies of viral biology and evolution.
And this really raises an important, maybe even provocative question that we, as people trying to stay ahead in this field, must continuously consider. Given the increasing human-animal interface through things like urbanization, deforestation, the global wildlife trade, climate change shifting habitats, and just ever faster global travel, how might the known geographic ranges and the zoonotic characteristics of these viruses continue to shift in the coming decades? Could we see viruses currently confined to one continent pop up on another more frequently?
That's a sobering thought.
And perhaps even more fundamentally, what new unclassified poxviruses might we identify next? Viruses that are currently lurking, perhaps relatively harmlessly, undetected in animal populations somewhere in the world, just waiting for the right circumstances, the right mutation, or the right human contact to spill over and potentially become the next emerging human pathogen. The discovery of NY012 reminds us that they're out there.
A truly fascinating and indeed a somewhat sobering thought to mull over, especially as our world becomes more interconnected and our interactions with the natural world intensify. The story of poxviruses, it seems, is far from over. We hope this deep dive has armed you with the knowledge to feel truly well-informed, perhaps even feeling like you've gained some of that expert-level mastery about poxvirus infections. Thank you for joining us on this rigorous journey of discovery.